Good day, ma'am and class. This is Group 5, and we will be presenting
Alpha thalassemia. Alpha thalassemia is a blood disorder characterized by reduced production of alpha globin chains, leading to an imbalance in hemoglobin synthesis. This case study focuses on a patient presenting with severe alpha thalassemia, outlining the clinical presentation, laboratory findings, management strategies, and long-term considerations. The patient profile is as follows. The patient was of age of 6, female, and Southeast Asian. The family history is that her uncle, maternal uncle, was diagnosed with beta thalassemia major. The clinical history states that the patient was brought to the clinic by a mother who reported persistent fatigue, pallor, and increased irritability over the past few months. Shortness of breath during physical activities and a poor appetite was noted. The child had been generally healthy until the age of 5 when she began exhibiting symptoms of anemia. Initially, her symptoms were mild and attributed to a growth stunt. However, the last few months her fatigue worsened and she developed noticeable pallor. Her mother reported episodes of tachycardia and episodes of abdominal pain. She has no previous blood transfusion and she is up to date with her email. Clinical presentation for the patients are as follows. The patient presented with the following symptoms being fatigue, pallor, irritability, and lethargic, palpitations, tachycardia, shortness of breath with exertion, abdominal pain, and poor appetite. The patient's vitals were as follows. Heart rate at 120 beats per minute, respiratory rate at 22 breaths per minute, blood pressure being 90/60 millimeters of mercury, skin was polar with jaundice or cyanosis, the abdomen was soft, non-tender with no hepatomegaly.
Pathogenesis. Alpha thalassemia is a disorder caused by abnormal production of globin chains. The globin production can be diminished or it can be absent for one or more globin chains. With the imbalance of globin chain production, it can result in the impairment of normal hemoglobin production. In alpha thalassemia, there is an abnormal or absent production of alpha globin chains. This is associated with more than 15 different genetic mutations. The severity of the condition is dependent on the mutation type, the most severe case being that the mutation is a non-deletion type where only one alpha gene has been inherited. This is called hemoglobin H disease. Diagnostic workup. A variety of lab tests were done to confirm the diagnosis of alpha thalassemia for the patient. These tests being blood tests, blood smear, and a high-performance liquid chromatography. The blood test results for the patient were as follows. A full blood count where red blood cells were 5.5 times 10 to the power of 12 per liter, this being above normal range. White blood cells were 11.6 times 10 to the power of 12 per liter, this being within normal range. Platelets were 315 times 10 to the power of 9 per liter, this being within normal range. Hemoglobin concentration was 8.3 grams per deciliter, this being below normal range. Mean corpuscular volume was 58 femtoliters, this being below normal range. The mean corpuscular hemoglobin was 18 picogram, this being below normal range. The patient's blood smear contained anisocytosis, poikilocytosis, microcytosis, hypochromasia, hemoglobin H inclusions, and target cells. the patient's reticulocyte count was 5 to 10%. The patient's HPLC contained hemoglobin A2, which is normal, hemoglobin F, which is normal, hemoglobin A, which had a decreased concentration, and hemoglobin H was present.
Treatment and management. The type and extent of alpha thalassemia defines how it is managed and treated. Individuals with mild variants, such as those with alpha thalassemia trait, require no specific therapy, and iron supplementation should be avoided to prevent iron excess. Folic acid supplementation may be useful in patients with hemoglobin H illnesses due to increased bone marrow turnover and hemolysis. However, severe forms of HbH illness may necessitate regular blood transfusions, particularly during infections or episodes of severe anemia. Individuals with alpha thalassemia may require more extensive therapy, including in utero transfusions and allogenic hematopoietic stem cell transplantation, which are only available at specialized hospitals. Iron chelation therapy is essential in situations needing frequent blood transfusions, such as HbH illness or hydrops fatalis, to eliminate excess iron and protect the heart, liver, and other organs. Chelation therapy typically involves the use of medications such as deferoxamine and deferasirox. Stem cell transplantation is a potentially cure treatment for alpha thalassemia, although it is risky and only appropriate for a small percentage of patients who can be matched with donors. Researchers are also looking at new treatments, including gene therapy and techniques to increase fetal hemoglobin production with the intention of improving management in the future. Common treatments include folic acid supplementation, blood transfusions, iron chelatin therapy like deferoxamine, deferasirox, or deferoprone, in utero transfusions, allogenic hematopoietic stem cell transplantation, splenectomy, stem cell transplantation, gene therapy, and inducing fetal hemoglobin production. So there are many challenges and considerations following thalassemia treatment. Following thalassemia treatment, patients and caregivers face a number of challenges and issues. These challenges, which are particular to the disease's outcomes and care, include iron overload management. Regular blood transfusions cause patients to develop iron overload, requiring the use of iron chelatin therapy. Thus, continuous treatment is generally expensive and might result in side effects such as gastrointestinal distress or liver toxicity. It demands lifelong devotion, which adds to the psychological strain of continuing therapy. Endocrine and bone consequences. Patients with thalassemia, particularly those getting long-term transfusions, may experience consequences such as delayed growth, bone abnormalities, and endocrine dysfunction such as diabetes or hypothyroidism. These issues demand extra medical procedures, increasing the medical and financial strain on families. Hematopoietic stem cell transplantation challenges. While HSCT may provide a cure for thalassemia, it is not commonly available due to a lack of appropriate donors, high costs, and the risk of transplant-related death and morbidity. Even after successful transplant, patients must be monitored on a regular basis for problems such as graft versus host disease. Psychosocial impact on families. The chronic nature of the disease causes considerable emotional and mental strain on patients, particularly mothers. Many suffer from depression, anxiety, shame, and social isolation as a result of cultural stereotypes around genetic illnesses. Family members frequently struggle to reconcile caregiving responsibilities with jobs, compounding their stress. Financial burden. The cost of lifetime treatment, which includes multiple monthly transfusions, chelatin treatments, and hospital visits. It is a significant financial strain for families. Cultural and social stigma. Thalassemia is considered a social stigma in many civilizations, leading families to hide the sickness from the society. Educational and social disruption. Children with thalassemia frequently encounter difficulties in school due to repeated hospitalization, exhaustion, and poor physical health, which affects their academic performances and social interactions. Long-term health monitoring. Following treatment, patients require ongoing monitoring to control therapeutic side effects, detect new problems, and guarantee adherence to Latin therapy. Because the disease is chronic, patients and family must attend many medical appointments, tests, and hospital visits, which can be demanding. Overall, this is a challenging disease. We have come to an end of our presentation. You guys can look at the following references to research a bit more. Thank you.